Well, hello everyone. This is Susan Snelling from the National Collaborating Center for Methods and Tools. It's a pleasure to welcome you to this webinar today focused on quality assessment of community evidence tools. We call it QACE. So let's get started. Now, first thing, the bad news, we've been having some connection issues during some of our recent webinars. So it's possible that we will have that today. I hope not. But if all of a sudden you are not able to hear anything, then you will have to reconnect by just hovering over the bottom of the screen until the toolbar appears, click on the audio button, and then click play, and the button should turn blue. So if that's the case for you, then please follow those instructions. But fingers crossed that we don't have any of those problems today. Our regular housekeeping items are asking you to use chat to post any comments or questions during the webinar, and you can send those questions to all so that other people can see your comment as well. And if you're having any connection issues, the number is there on the slide as well as under chat. And if you have ongoing audio issues, exit your audio connection and then reconnect. But hopefully we're all set to go today. If you want to go back and listen again or look at the slides will be there at the link on slideshare.net under NCCMT and then to presentations. The audio recording will be available in English, which is the language of today's webinar, in about a week. So that's under our YouTube channel at NCCMT. So first of all, just to start with a poll kind of makes it feel like we're all in the room together, even though we're not. How many people today are there watching the session with you? Maybe it's just you or a handful of people or maybe a larger group. So we'll just wait a moment. So have you visited the NCCMT website or used its resources before? That's an easy one, yes or no? And then just moving on, if you have, how many times have you used the NCCMT resources? Is this maybe a first time for you, or have you been there a couple times? Maybe you're a regular. And then just a little word about NCCMT and the National Collaborating Centers. There are 6 collaborating centers across the country, and we're the National Collaborating Center for Methods and Tools is shown at the bottom in the middle. But there are lots of good things coming out of all of our partner collaborating centers. Our work focuses on methods and tools for evidence-informed decision-making. So that's really one of the goals of our session today, is to talk a little bit about evidence-informed decision-making. So feel free to check out our website at nccmt.ca to find out about all the things that we have available. We're talking today about something that speaks to evidence-informed decision-making across public health, specifically the quality assessment of community evidence tools. So my name is Susan Snelling. I am a senior knowledge translation specialist with the NCCMT, and I'm really pleased to be able to talk about these tools today You have no idea, actually, how pleased I am to talk about it since we're getting off to a little bit of a late start. But I think we'll all get through just fine. So I'm going to talk just a bit about evidence-informed decision-making in public health to set the context, then talk specifically about what we mean by community evidence in public health, and then get to quality assessment of community evidence, which is really the title of this new tool, QACE, or Quality Assessment of Community Evidence, and then put all of that into context about where to go once you've interacted with the tool. So the National Collaborating Center for Methods and Tools, our focus is curating evidence, sharing knowledge, and building skills. We want to support the use of the best available evidence in public health practice and policy to optimize health across Canada. And we support public health professionals in finding and using high-quality, up-to-date methods and tools to build capacity for evidence-informed public health. So what is evidence-informed public health? It's the process of distilling and disseminating the best available evidence from research, context, and experience, and using that evidence to inform and improve public health practice, programs, and policy. And I'll draw your attention here particularly to that terminology, best available, because this will be really important and is one of the purposes of the QACE tools that I'll be talking about. Now, you're all experts at using the chat room on this interface, because we were just doing that. If you have questions or comments, please feel free to put those in chat at any time. I may hold responding to the questions until we reach a break or until closer to the end, but we definitely welcome your comments and questions and encourage those to happen through chat. So we're talking about best available evidence, and one of the ways of thinking about evidence is through this model of evidence-informed public health. Maybe familiar to you already. This is not a new model for us. But the implication here is that when we think about evidence-informed decision-making, the evidence that we're talking about there includes research, but also things like community health issues and local context drawn from surveillance data or community health status reports, for example. We also draw from evidence about community and political preferences and actions. So some of that might come from newspaper stories or community focus groups. And also in our evidence, we consider what resources we have to work with, both financial resources and human resources, to take action within public health. And so then we bring all of that together with our public health expertise and make decisions about what's the best intervention to implement. So we'll be talking about all of this evidence today, but in particular, we're talking about community evidence. And so by community evidence, what I mean is evidence for those local issues and contexts. So might be surveillance data, might be community health status report, that give us a sense of how big or how important, how prevalent an issue is in a local community. And sometimes we also look to community evidence to tell us how important an issue is relative to other community health concerns. So a lot of people are affected by this, but even more people are affected by another problem. So some of that community or local evidence helps us to put issues into a larger context and helps us to set priorities. And then also by community evidence, we mean evidence about preferences and actions. So what do community members prefer in terms of their interventions? What would be accepted in a community is not the same across communities necessarily. So stakeholder organizations, consumer groups may provide evidence of community preferences. Commentary from the government or public officials supporting or opposing a certain course of action can also be considered evidence that guides our decisions about what interventions to implement. And then other ways of understanding the current political climate. Sometimes it's just not the right time to do something, even though it may be in its own right an effective intervention. So all of these things are what I'm talking about when I talk about community evidence. We know that community evidence is contextual, it's local, and that makes it different in some respects from published research evidence. So published research evidence may not have that local flavor. It's still really relevant to decision making because it can give us an indication of what interventions work and for whom they work. But we also, of course, want to understand what will work in local community. And we know that some things that work in one setting may just not work in another or may work less well. So that's the kind of evidence that the QACE tool is designed for. And I'm pretty sure that using community evidence is not something that's new to you. We've always done that in public health, bringing that context, that local flavor into decision making. But I think that we haven't always been rigorous about the quality of that community evidence that has or should be influencing our decision. And so when we bring concepts of quality assessment or critical appraisal, we start to see a gap in tools that allow us to really assess the quality of the evidence. So that's where the QACE tools come in. When I'm talking about quality assessment, remember that part of the definition that evidence-informed decision-making in public health uses the best available evidence to inform decisions. Well, you can't really know what's the best available unless you do quality appraisal. So we recognize that if we're going to talk about the best available, we need on some level to be able to assess the quality and answer the question, is this of good enough quality? Is it the best available in order for us to use that evidence as an influence in our decision making? So putting it all together, quality assessment of community evidence, well, we know that there are existing tools to appraise the quality of research evidence, and you probably know some of those tools, checklists. Agree-to is one of them. There are CASP tools, many other tools that we use to appraise research evidence. But as I've just been saying, research evidence is not the only influence on our decisions, and so at NCCMT, we were asking ourselves, well, how can the quality of community-based evidence be assessed? Those research tools don't always work that well for community-based sources of evidence because community evidence is just different. It doesn't have the same standards that research evidence has. So we wanted to see if there was a tool that would allow us to do a similar thing to what we use for research evidence and appraising the quality of those sources, but for community evidence. So I won't go in great detail in terms of how we developed these tools, but first what we did was just look to the literature, both the academic published literature and gray literature, to see whether there were tools that would allow us to do a good quality appraisal of community evidence. And we really didn't find anything that altogether covered what we thought was important for community evidence. There were little bits and pieces that we drew on, but there was no one tool that really did it all. Also in the development process, we had focus group sessions with public health professionals and other feedback along the way from librarians, people who work in public health, and so on. So we thank you for your input if you were one of those people who talked to us about it in the early stages. From looking at the tools that we did find and talking to people about their thinking about what quality means when we think about community evidence, we came up with these 3 dimensions. And this is really, I think, one of the key takeaways for today and for these tools is that there are, it seems, 3 dimensions to assessing the quality of community evidence. First of all, you want that evidence to be relevant to the decision you need to make and to your local context. And as I talk a little bit more about this, you'll see that there are times when relevance is on a continuum. It's not completely spot on, but you need to ask yourself, is it close enough? Is it relevant enough that we could still stand to use it in our decision making? Second dimension is that we want the evidence to be trustworthy. So we think here about the methodological quality. How was that evidence generated? We want methods that reduce bias, are transparent about the conclusions that are drawn so that the conclusions are somehow related to evidence. We think about concepts like richness or saturation or the adequacy of the data to really represent the phenomenon in question. So some of those terms that we see from qualitative research, saturation, for example, goes into being trustworthy. And be cognizant of research evidence. So not that the community evidence has to tell exactly the same story as the research evidence, but that at least somehow it makes sense in the context of other things that we know about the intervention that we're thinking about based on research. So all of that goes into trustworthy, the second dimension. And then in public health, we're always trying to think about equity considerations in the evidence that we bring to bear on our decision making. And so a third dimension of quality, that is what goes into deciding whether evidence is good enough for us to use it in our decision making, is that it is equity informed. So the kinds of things that we think about when determining whether evidence is equity informed is that the stakeholders were engaged in sharing their thoughts or contributing to the evidence, that the evidence in some way is representative of a community or the community of interest. Concepts like being intersectional, so representing different subpopulation groups, understanding the connections between different populations and different groups. Being inclusive is another aspect of quality when we think about community evidence. And then ethical data collection, whether the data were collected in a culturally safe way, is also part of what goes into that equity-informed dimension. So each of these 3 dimensions informs the quality of community evidence and really should be assessed before the evidence is used to influence decisions. So as an extreme example, if you had evidence that someone brought to you about a particular intervention, but it really was not relevant, was not trustworthy, and was not in any way sensitive to equity concerns, you'd probably feel comfortable saying, I'm not even going to look at that evidence. I'm not even going to use it. But most cases are not as clear-cut as that. Most cases are not like absolutely not relevant, absolutely not trustworthy, absolutely not equity sensitive. It's more nuanced than that. And so that's where the CASE tool and the questions that go along with it really help you to dig into these dimensions in a little more detail so that you can determine whether this evidence is good enough and whether it's the best available. So if you go to the website, nccmt.ca, and look at the CASE tools, like QACE, you'll see that there are 2 tools and a user guide. And this diagram is from the user guide, so it guides you through the steps of using the tool. It's not rocket science. I think you probably would have figured it out anyway. But just to talk through very quickly, there are 2 tools, so you have to choose which one you're going to use, and that depends on the kind of evidence that you have. Is it population health and surveillance evidence? That's the yellow bubble. Or is it more community-based sources, focus groups, that kind of thing? Then you would use the tool. They both cover those 3 dimensions of relevance, trustworthiness, and equity, being equity informed. But they have slightly different questions just because the nature of the evidence is a little bit different. So not all the questions that are listed on the tool will apply to every type of evidence. So the tools are meant to be flexible. It's not that you have to complete every question. Sometimes they don't apply, and you're in the best position to judge that. We do suggest that you may wish to do the quality assessment as a team, bringing community members even to determine whether evidence is of sufficient quality. If it's about their community, they're probably in the best situation to be able to address that question. That's not the case all the time. Sometimes you can do quality assessment just sitting at your desk, but sometimes it would benefit from being a very community-embedded approach. So then, like with most of these checklists, you consider the applicable questions and develop a brief answer. There's a way on the form to keep track of those as well. And ultimately, you're trying to get to the big question, which is the quality of the evidence good enough to influence your decision-making? The tool is designed to be used for one piece of evidence at a time, so you may repeat the use of the CASE tool with other sources of community evidence. And then once you've looked at the quality of all of them, then you would move on to synthesize, bring it all together, and ultimately move forward with your decision-making. So just a couple of comments about what's not here as part of the process. These are not tools that come up with a score, so don't look for that. It's not there. And the reason for that is that these tools are meant to be flexible. Some questions will apply to the evidence that you're thinking about, others won't. It's much more of an impressionistic approach. Certainly you could score it if you wanted to compare one across the other, but we're much more interested in the nature of these features within each evidence source rather than a firm score. So it's not intended to be scored. And the tools can be used certainly for people who are preparing evidence briefs or pulling something together to assist their team. So health promoters, epidemiologists, nurses, inspectors, specialists, you know, anyone working in public health could certainly benefit from using these tools, and probably in fields beyond public health. But also for people who maybe work in support roles. So if people come to you and say, well, I have this report, can I use this in my decision making? Can I put this in a presentation? Can I bring this forward to influence our decision making? Going through this tool will help you to determine whether the evidence is of sufficient quality to be included in a presentation or shared more broadly. So that's part of the context for who might want to use the tools. So as I mentioned, the tools which are available on the website, there are two of them. They're very similar in nature, but there are slight differences because of the nature of the evidence that each one is designed for. So we called them very creatively Tool A and Tool B. Tool A is for community health issues in local context. So here we're looking at surveillance data, community health status reports. Tool B is looking more at community and political preferences and actions, so that might be community focus groups, newspaper stories, something that really talks about community perspectives and preferences. Both of them together have the same goal, which is to answer the question about, is the evidence good enough that I should use it in my decision making? So if you look up the tools, this is what it looks like. So the one that we're looking at is Case Tool A for quality assessment of evidence for local health issues in local context. And the questions that you're meant to answer are on the first page, the page to the left, and you'll see that those three dimensions are represented. There are questions about, is it relevant, is it trustworthy, and is it equity informed? And then there's space for you to record your answers, your thoughts about that. On the back of the page, or what's shown here on the right, is some additional sources. So as I mentioned, we had looked to sources to see if someone else had already created a tool. And what we found is that there were bits and pieces, certain tools out there that spoke to some elements that we thought were relevant. And that's what you're seeing here, is some of those tools that speak to some elements of quality assessment for community evidence. But none of these we felt sort of did it all. So there's a question, why would we want to do a quality assessment on a newspaper story? Well, so it sometimes happens that as we're trying to decide on an intervention, we start to see discussion of that possibility in newspapers. And I think you've probably been in the situation, I sure have, where people start to say, oh, well, you know, people in the community are against this. How do you know? Newspaper story. Okay, well, so that is community evidence of a sort. And what we want to ask ourselves, as we would ask for any community evidence, is how good quality is this evidence? Is this quality good enough that I would want to use it in my decision making? So in other words, we're saying, does this newspaper story or a letter to the editor have sufficient quality that that I should pay attention to that I should have that be one factor in my decision making? And I'll talk a little bit more about an example of that may clarify even a little bit more. And then another question, so did we ask communities, were community members involved in the tool design? Not in our development, other than members of the public health community, which is really our target audience. But you'll see that in the list of tools that we did consult, many of them, particularly for Tool B, which is the really sort of community-embedded tool, drew extensively from understandings of community engagement, participation, culturally safe practice. And so we drew from those sources that were were community involved and community engaged. So I'll just walk through an example of a particular decision that we might be wanting to make. So should our community implement an emailed vaccination reminder program? And I'll just comment that this is just an example. You won't have the answer to this question by the end of this webinar. But it sometimes serves to just have an example to really think about this. So, you know, let's say someone comes to you and says, oh, okay, I heard about this email reminder idea at a conference, or I read about it online, and I think we should consider sending out emailed vaccination reminders to people in our community. But I want you to help, you know, I want you to pull together some evidence or help me with that. So what do you do? Well, probably, and this is the suggestion that we would make at NCCMT, if someone comes to you saying, well, you know, I'd maybe like to think about doing a particular intervention, that you start with the research evidence. So start with that purple bubble. And so I did that. I went to health evidence. I'd probably do other things too if I were doing this for real, but it's an example, so we'll just go with this for now. So there is a systematic review on health evidence about the effectiveness of email-based reminders to increase vaccine uptake. You can see there that it has been quality assessed using one of those quality assessment tools that is used in health evidence as being of moderate quality. So the conclusion that they come to in the systematic review is that emailed reminders do appear to increase uptake compared to no reminders. There are some other caveats and things to know about this, but remember, I'm not really trying to answer this question, just really to show you how it works. But, yeah, okay, so there's some evidence that from research that implementing an email vaccination reminder program is effective or would be effective. Okay, so should we go ahead with it? Well, one of the things that you are probably likely to do is to think about what we know from our own community. That's where the CASE tools come in. So we'd be asking that question about local health status data on vaccination rates. Because if your local vaccination rates are already quite high, you might not need that intervention of emailed reminders. Even though it's an effective intervention, if you don't have that problem or issue in your community, you maybe don't need it. So that's where the community evidence would start to come in. And another source of evidence might be data on how much of your local population has email access, because logically, if people, if it's not widespread to have email access, email vaccination reminders are not going to reach everybody. So this is the kind of thinking process that I'm sure you're used to when you start to look at whether to implement an intervention in your local community. So one of the questions, though, we have is if we find that health status data or we find data on local email access, how can we know it's of good enough quality that it will actually help us and not kind of lead us in the wrong direction? That's the purpose of the CASE tool. CASE tool doesn't make the decision for you. It's a quality assessment tool. So here's the first chunk of questions on the tool. Is this evidence relevant? And I'll say, by the way, that if you really conclude that that evidence is not relevant to the question you are asking, you don't even need to go any further. We put relevant at the beginning kind of as a filtering step. So if it's really not on your topic of interest, the indicator is just not the right one, it doesn't allow you to determine how big this issue is relative to other issues, it's just not available at the local or regional level, which sometimes happens, then you might say, this evidence just is not going to help me, so I'm not going to use it in my decision making. But if we think about that evidence like local health status data on vaccination rates, you would probably say that those are in fact relevant for the decisions that you need to make about whether an emailed vaccination reminder process would be useful. Or if you're thinking about evidence on how much of the population has email access, you might find data only for your province, let's say, and not at a local level. But as I said, these questions are meant to be flexible. It's not like, you know, if you can't answer yes to every one of them, then the quality is not good. So maybe having data at the provincial level is good enough. That is, that having local level data is not that important for the topics that you're interested in. Some things are universal, and so, or pretty close to universal. So it's not to say that every question has to be answered at the local level. We like to see that for sure, but sometimes that wouldn't be super important, and you'd be comfortable to say that it's probably good enough that you would continue to look at this data. So a question about the type of indicator, what could tell me if one health topic is more important locally compared to another? The priority setting or the importance is probably something that you'd have to make a judgment about. But yes, for example, prevalence estimates would let you know that this is a really low incidence phenomenon, or maybe in our example here that your vaccination rates are pretty good and maybe even better than other jurisdictions on everything except for one particular vaccination. So then you would know that, you know, the focus is on that one as opposed to others for your community. And then the philosophical question, do different sources of evidence hold different value depending on who is making the decision? Well, I think you can probably answer that for yourselves from your experience. Absolutely. And that's why, from our perspective, to have some way of somewhat objectively assessing the quality of the evidence is helpful, because it allows us to surface some of those areas where people would say, but I really value this evidence. Like, I really value this insight from a community focus group more than the local statistics. And that's legitimate. You know, people can have those different perspectives, but it's helpful to be able to say, well, why is that? What kind of quality markers do we see in this surveillance data and in this community focus group data that allow us to be more comfortable using one or the other? But ultimately, that decision-making process does absolutely become a question of values, of, you know, what gets included and what's not. Public health expertise brings it all together, and so there is a human element for sure in the decision making. The second group of questions is about, is the evidence trustworthy? And again, some of these questions just might not apply, like might not be possible to answer. So, for example, like if you just had a letter to the editor. Letters to the editor don't usually talk about their methods, although they might say, everyone on my street thinks this or that. But usually we're not going to be able to really go in depth to say what was the methodology that produced this letter to the editor. So those questions just wouldn't apply for that kind of evidence. But we certainly can look at the methodology of surveillance data. We can look at the methodology behind what goes into health status reports and so on. And the kinds of questions that we're asking are, was this an appropriate method? Did they reduce the risk of bias? Might there be conflicts of interest to keep in mind? So, for example, if you have data from an internet provider saying, oh, email is the greatest thing and we should send all of our information through email, well, that might be true, but we'd want to know what was their evidence. And the fact that they're an internet provider might make us think that there might be some bias potentially in the evidence that they would bring forward. So that's the kind of conflict of interest that we might want to keep an eye on. If the source draws a conclusion, like everyone should use email for everything, well, what's the evidence for that? And have they been clear about how they got from the evidence they were looking at to the conclusion they made? Does it connect to other available evidence? Not that it has to tell the same story. That's often why we go to community evidence, is that it's not telling us the same story as the research evidence or evidence at a provincial or national level. But that concept of triangulation that we know from qualitative research applies here as well, that on some level we want the evidence source, whatever it is, to at least not be outright discounting other sources of information that may come from research or other sources, for example. And then always we're thinking about what are the gaps, what's missing, and how important is that gap to a complete understanding of the issue. There's no perfect data. There's no perfect evidence. Nothing answers all of our questions. There are gaps and limitations in research evidence as well as in community evidence. The question is just how limiting are those limitations? Do we still find something here that can contribute to our decision making, or do we really feel that this is not adding anything to our understanding? And then the third cluster of questions from that third dimension is about being equity informed. So when we're thinking about health status data, surveillance data, we ask ourselves, well, okay, how representative? What's the level of analysis and reporting? Is it down to the neighborhood? Can we get at certain subpopulations? Where are the gaps in, like, who's represented and who isn't? Who was included in the data collection? Were people engaged in providing data? Are there certain population groups that are systematically excluded, like people without telephones, and so on? For some kinds of data, that might not matter. For others, it might matter a lot in terms of how much you really feel confident using the data in your decision making. And then were the data collected in an ethical way? Was it culturally safe? Did they abide by tri-council policies, OCAP principles, if that applies, in Indigenous communities? Were communities consulted about whether they wanted to provide data, or were these data somehow used without people's permission? Most of the time in public health, that's not the kind of surveillance data we're using, you know, like stealth data. But it could happen that some data that crosses your path that maybe you shouldn't have, maybe shouldn't have been made public. And that becomes a question of whether this is data that you should even be using. So we've looked at case tool A and those three dimensions, the questions that allow you to dig into each of those dimensions. And just a couple of comments. So a great tool for stimulating discussions around EIDM. And absolutely, that's what we think is probably most important about this, is just having those discussions about the quality of evidence. But wondering, does the case tool perform differently depending on who is completing it? It might. A member of the public might rate a public source of evidence higher than a researcher. Absolutely. And that's one of the reasons why we don't really aim for a score here. It's much more of an impression, and if you want to have good representative impressions, you probably would want to have more than one person answering that question. So a team, a member or members of the public included, and so on. Great insights into how this might be used. So that was case tool A when we're thinking about surveillance data and so on. There's a parallel kind of tool still looking at the same sorts of dimensions, relevant, trustworthy, equity-informed, but the questions are just a little bit different because the evidence sources for community and political preferences and actions are a little bit different too. So for example, still trying to answer our question, should our community implement an email vaccination reminder program, you might look to focus group data to see whether parents as one group might support that. It's not the only source, but that might be where your focus group data comes from, is from parents. There might be other similar programs to look to that you've maybe used email reminders for something else, and you could draw from that to say, well, what did people think about it in that other context? So again, I won't belabor the point, but there are questions about whether those data are relevant. So here we're asking, is it clear what's being asked? Is it on topic for what I want to learn about? Does it apply to my community and to the settings that we really need to understand? Is it trustworthy? So same dimensions, the questions shift a little bit. For methodology, we're just really getting you started with some of these questions, but if you really want to determine whether the methods reduce risk of bias, there are whole questionnaires that help you to do that, like the Grade Circle as one. And so on the back page of the tool, that's where you'll find additional sources, and we do encourage you to use those methodological rating tools that are appropriate for more qualitative kinds of data, because those can really help you understand what kinds of bias may have crept into your evidence. And not that bias never creeps in, it does. But we're trying to get to, is it serious enough that you would not use that evidence altogether, or is it still good enough to influence your decision making? And then the third group of questions is about, is the evidence equity informed? And here we really start to ask about, if this is community evidence, well, how representative is it? Are disadvantaged groups being heard and represented? Who would be affected by our vaccination reminder program, and whose voice might not have been heard when we were pulling together evidence about whether this is a good idea or not. You'll see in the case tool B that we're looking at now that we really have some questions about engaging stakeholders, how participatory was the process of gathering the data. So for example, in a community focus group, was it a focus group of people who actually might get those vaccine reminders, or people who are in a subgroup who are known to have lower rates of vaccination and therefore might benefit from those reminders? So we really want to understand how much members of the affected groups were present in that evidence that we're thinking about. There's one way of thinking about that, the IAP2 spectrum, were people informed, consulted, involved, collaborate? Did they collaborate, or were they empowered? And it's not to say that you're always going to have evidence that came from a community empowerment point of view, but if you know that there was a really low level of engagement with the community, that might make you say that the evidence is not as good quality as something that really pulled the community in and got their insights. And then we still have questions as well, of course, about whether the data were collected in a culturally safe way, in an ethical way, and so on. Sometimes you'll also see that communities were involved not only in providing the data, but in interpreting and sharing the findings. You don't see that all the time. That's not a reason necessarily to say that the data is of poor quality, but that is a marker of a really high quality community engagement process. So you've pulled all this data together, you've done the quality assessment, and so now you're still trying to figure out, well, should our community implement an email vaccination reminder program? Well, I don't know. But what I do know is that you will undoubtedly want to try to answer that question by using various sorts of evidence from research and from community health knowledge, local context, and community and political preferences. Will people welcome email reminders? Have you tried that before, and do you have some evidence that it worked? Maybe in community focus groups with parents, there was a question about ways to reach them, and maybe email was something that they suggested. That would be evidence that you might bring in favor of doing this program. And then you'll notice from this model that there's something that we haven't talked about, and that's the resources bubble. There may be some really effective interventions that would be well supported in the community. There's a need for them, and we need to determine whether we can afford it, whether we have the human resources to do it, whether we have the training that's needed in order to deliver that intervention. So resources also come into our decision about whether a particular intervention is right for our community. And it might work well in another community and not in ours because of resource constraints. So we are working on a tool to help you think about resource evidence in a little more detail. It's not quite ready, but stay tuned because we're definitely working on that so that we have a full rounded perspective of what goes into each of these aspects of evidence that come into decision making. So as I said, on the back page, the second page of each tool, you'll see that there are other resources. So I've pulled out here other resources that you can go to, other tools that will help you dig in more detail. So you wouldn't use all of these all the time, but if you have a study focus group, for example, done in your community, but you really want to evaluate the methodological quality of that focus group, there are tools that will give you more detail on how to do that. So use the ones that are appropriate for you. You'll also see there, for example, that there are tools for ethical analysis of surveillance data. So you can use the QACE tool as a first pass on quality assessment of community evidence, and then if you really feel that you need to do a little bit more to fully understand that, there are tools there for you. Or if there are differences of opinion, maybe that's when you would go to another tool as well. So we drew from many of these tools in pulling together the CASE tool, but of course the CASE tool is maybe at a higher level of abstraction than some of these other tools that are more detailed in specific areas. So we're sharing our background information with you as well. So you've done quality assessment of the research, which you're probably used to doing, but now of the community evidence that you have as well. Well, I'm sure you know from experience that just saying, well, we've got good quality evidence that shows we should be doing X is not enough to be sure that that happens. So in the wheel, as shown here, once you've gone from that appraise step, which is the yellow, that's where we've been focusing our attention today, there are still some steps to do. So synthesizing, bringing all of that information from the different evidence sources together. And in that process of synthesis, you would describe the quality of all the evidence. And some dimensions might be weighted more heavily than others because of their quality. So we have some high quality research evidence that says one thing. We have some low quality local surveillance evidence just because it isn't really on topic, or we don't have anything on that, or maybe just a little bit. So there's not too much there that's going to influence our decision. And then we have some really robust community evidence from focus groups, let's say, or intel from particular population groups who are really going to be affected. So it's like the bubbles in the 4-bubble model kind of grow or shrink depending on how much evidence and how good quality the evidence is in each of those. So you'd be synthesizing all of that together, as well as identifying whether there are still unanswered questions, whether maybe you still need to collect more evidence to fill some of those gaps before you can go ahead and make a decision. You can't do that all the time, of course, but sometimes there are opportunities to say, let's go to our community, let's see if we can ask people what they would feel about a particular intervention. And then moving around the wheel, you want to, whatever you've been brought together, adapt that to your local community. Interventions look different in different places just because of the different contexts. Implementation is the next step, and then so moving into those recommended actions based on the best available evidence that you've been able to find. And then evaluating, of course. You want to know how well that's working in your local community, particularly if there are some gaps in the evidence, like you don't really know, it hasn't been tried before, so you're going to try it maybe as a pilot. Those are the really important times to be assessing or evaluating the results of what you've implemented. So that's the run through the new CASE tools, the CASE tool A for assessment of evidence for local health issues and local context, and CASE tool B, a similar tool for evidence on community and political preferences and actions. We would love to hear how you're using this tool, how it's working. This is brand new for us, and we hope it's useful, but we really look to you to help us to understand, to refine if there are other resources that you think would be helpful. My email is there. You can always send an email to nccmt@mcmaster.ca, and we thank you very much for your attention. So I'm happy to take questions or comments in the chat box. So go ahead and type those in if you do have questions. we will send you a little survey once you log off, and we welcome your insights. Sorry again for the challenges at the beginning, but we'll certainly hope that this was useful for you. So we do have one polling question there that I think people are answering just to give us some feedback. So are there any questions? So thank you, interesting. Okay, thanks for sharing, great. Well, that's good. I'm glad you're enthusiastic about it. Really, I do encourage you to try it out. Tell us how you're using it. Ask us any questions. You know, it's there for you. So if there's anything that we can do to help you do quality assessment of community evidence or to understand how best to use these tools, we would really be happy to do that. So question here, I'm curious to know if the entire process, the 4 bubbles, would vary depending on the extent of stakeholder involvement in the review process. Yes, absolutely. And I think, you know, we always keep in mind that evidence-informed decision-making in public health needs to be efficient. So yes, we want to make good decisions based on evidence, and we have to get on with it and you know, make our decisions and start implementing and doing things that are going to benefit of our community. So we don't want to set such a rigid goal that we have to have stakeholder engagement of this kind to this extent on every single thing. It probably won't work. I mean, if you can figure out a way to do it, I think it's fantastic. But I think the process needs to take into account what's at risk. You know, how serious a decision is this? Would we have to give up something else in order to give something over here? Would stakeholders be likely to have different perspectives than what we would have, and which stakeholders? So lots of questions about how to, who should be involved and how much, what's respectful for stakeholders and a good use of their time. So yeah, I mean, it's a whole process for sure. Another question on the applicability and transferability tool from NCCMT. So that's a tool that we would tend to use in the ADAPT step. So I'm just going back. Once you've appraised the quality, then, you know, to a certain extent, you've kind of filtered out the garbage, things that really have no business influencing your decision because they're like, you know, one person said it one time and, you know, there's lots of evidence to the contrary or something really biased has shown up. You don't need to look at that if there's something better. So you're doing the appraisal, you're synthesizing everything, maybe in a briefing note or making recommendations or so on. Once you have a sense of what you're going to do, like you've made almost your decision, that's when I would say the adaptability and transferability tool, which is an NCCMT tool many of you are probably familiar with, that's when you would use the A&T tool to really say, how does this intervention need to look in our community? Who's going to be involved? How's it going to work? Are we like sure that this is the right way to go? Are there any unintended consequences? You know, who's going to benefit? All of those kinds of questions are more when you're like just at the cusp of implementing a decision. That's not to say that you can't use it at other times, and certainly there are some of those adaptability and transferability kinds of questions even in the QACE tools. So it's not really rigid, but the A&T tool is probably closer to that decision point, whereas the appraisal is bring me all the evidence, here it is on my desk or my laptop or wherever. Let's kind of go through it all and see what stays in the decision-making process so that we're basing our decision on the best quality. And then just one other comment, I think it's probably dependent on who gets to make the decision, who should be involved, and to what extent. Absolutely, decision-making is a cultural product. It's a product of how your organization works. It has its hierarchies and power structures, and so many of the tools that we looked at for developing particularly the Tool B questions that talked about community engagement, participation, all of those great concepts. We want to see those in our community evidence, of course, but it's also interesting to think about how are we doing in terms of community engagement and public participation in our decision-making overall about what we do, what evidence we look at, what interventions we ultimately choose. These are huge questions which we won't certainly answer today, but they're great to think about and, you know, maybe appraising the quality of our own process. You know, we're community, we're evidence generating as well, so it would certainly be possible to think about our own decision-making process and the quality of the inputs and the quality of what comes out of that. That's a webinar for another day, but certainly an interesting question, so thank you for that. All right, folks, thank you so much for sticking with this. We'll try to get those audio issues sorted out so that we don't have to, you know, do those fitness breaks as a start to the webinar. But you know what? Maybe it's a good idea. Maybe we should do it from here on in. So have a fantastic day. Thanks, everyone. And as I said, please stay in touch. Let us know how you are doing with these tools or if you've got any questions about them. Take care. Bye-bye.